right, well, welcome everyone. Thank you for joining us. We'll start off by just having you introduce yourself. So John, why don't you start with you? Tell us who you are, where you're from, when did you discover you had cancer, and what kind of cancer was it?
Yeah, my name is John White. I'm from North Attleboro, Mass, just about 45 minutes. Well, let me rephrase that. About an hour and a half from here. I was diagnosed with stage 4 metastatic prostate cancer 5 years ago. I went through conventional treatment for a year and a half, chemotherapy as well as hormone deprivation treatment, and failed it all miserably. I kind of in a dire situation. Then my oncologist told me that, with conventional treatment, I might have a couple of years. When I failed all the conventional treatment, my doctor decided that we're going to try something experimental. And we went to, typically when you're a stage 4 patient, your prostate is not removed. In my case, it had to be because we were dealing with something a lot different. And it was found that I had a neuroendocrine differentiation with lymphocytic infiltration, which kind of put me in a different situation altogether. At that point, I was given 3 to 6 months to live. We had the prostate tumor removed and sent to Foundation Medicine in Cambridge, who did their CDX panel. And I tested for 232 mutations out of a possible 430, I believe. I have none of the mutation variants that could be effective. I was PD-L1 negative. I was microsatellite stable. But the fact is, I'm a high mutation burden that Dr. Gaynor mentioned earlier that could possibly be a treatment option. I've had 44 infusions over 3 years. I presently still in treatment. I'll have my 45th in September. I went from 3 weeks to 6 weeks to 12 week. And I'm currently in complete clinical remission, no evidence of disease as well, which is unheard of for prostate cancer.
That's great. John, we're going to come back to you to talk about the genomic sequencing and all these various things that you mentioned. So, but first, let's move to Denise. Denise, your son Cole was diagnosed with cancer at the age of 2. So, why don't you start? Tell us a little bit about your experience.
Hi, everybody. We are from Florida. Cole was 2 years old when he was diagnosed with pre-B ALL. Leukemia. It was in his bone marrow at the time, and he went through 3.5 years of chemotherapy treatment. He was almost 5 years treatment-free when he relapsed in both his bone marrow and his central nervous system. So at that time, the first time he was treated at our local hospital, he was on a children's oncology group protocol, standard treatment. When he relapsed, we found out through a normal eye appointment, an eye exam, where the optometrist found that he had swollen optic nerves. So that led us to an ophthalmologist, that led us to an MRI, and it led us to the testing of both his bone marrow and his spinal fluid, and they both were positive. So he started going through treatment, chemotherapy treatment. Within the first month, his bone marrow, he was found to be in remission in his bone marrow, but not in his central nervous system. So it was at that point that we knew we needed to go someplace different because he wasn't responding to his chemotherapy. So through the course of the first time when we went through this, I actually started a couple of relationships with people that had gone through something similar to Cole, one of which needed a bone marrow transplant and came up to Dana-Farber Boston Children's to have that the transplant done here. And so I just started talking to a lot of different people and looked into different institutions, and ultimately we had decided that Dana-Farber and Boston Children's was right for us. So we came up here, and Cole started, or resumed, I should say, his chemotherapy treatment. It was persistent, made us very worried for at least a couple-month period of time because he wasn't going into remission. So during that period of time, it was thought whether we were going to continue with multi-year chemotherapy or he would need possibly a bone marrow transplant. So Cole actually has a twin brother and a sister that's 2 years older. They both got tested for their bone marrow, and his brother, Michael, was found to be a 10 out of 10 match. So when he wasn't responding as well to the chemotherapy, it was reducing his burden, but wasn't totally doing away with it. They had indicated to us a bone marrow transplant was the route we needed to go and to get him to remission. So luckily, Dana-Farber had access to a couple different chemo drugs that we otherwise wouldn't have been able to do. And lo and behold, he ended up going into remission. So at that time, we prepared and we got him into to his bone marrow transplant. He then had a lot of different side effects. All of the usually could happen, but usually doesn't happen, did happen to Cole. And he ended up spending 7 months up here in Boston. So we were able to bring him back home after his transplant, and 3.5 years later, last February, he relapsed in his spinal fluid. So luckily we had the relationship that we had up here, and we had been hearing about immunotherapy and specifically CAR T, and so that led us to the path back here last year. Last June, Cole had his infusion, and today is doing well and no evidence of disease. Anything you want to add? You sure?
Cole, what was the treatment with chemotherapy like, and how was the treatment with the CAR T therapy different?
Well, I would say chemotherapy takes like a more toll on your body, and I feel like it takes longer as well, and like.
Okay. All right, we're going to come back to both of you, but first we also have Ernestina down here. Ernestina, please tell us a little bit about you and your experience with cancer.
My name is Ernestina, from Rhode Island. I have my whole family here. I'm very sensitive to cry, so I'm sorry.
It's okay. It's okay.
I got diagnosed with cancer in 2015, brain cancer. And thanks to my daughter, she did everything to bring it to the Dana-Farber. And I don't know, can you? Is it okay?
Mm-hmm. Sure.
I'm sorry.
This is Josileny, is the daughter.
That's my daughter.
Right.
She did.
We know that it's really difficult to do this on your own, so this is a perfect example of
Thank
how
you.
support can be helpful.
So she got diagnosed in 2015, and actually we were getting ready to get started with chemo treatments in Rhode Island. And I just kept hearing about Dana-Farber. I actually grew up in Boston, so I just kept hearing about Dana-Farber. And we actually got in to see Dr. Reardon one time, and he talked to us about this clinical trial. And when we heard all of the risks and everything, and we're like, wow, it's terrifying. You know, I don't know if I can do this, and it was scary when we heard all of the can't even talk.
Statistics.
Exactly.
Yeah.
But then I remember when we had scheduled her appointment for her first treatment with chemo in Rhode Island, and I said to her, I think we should go to Dana-Farber. And her appointment was at 7 o'clock, and we woke up at 3 o'clock in the morning, and I said, let's go. We called, and I'm like, I need to see Dr. Reardon. They're like, well, you don't have an appointment. And I'm like, we're seeing Dr. Reardon. And we drove here. We got here maybe 5 o'clock in the morning. And I remember Dr. Reardon brought out the paperwork. I said, let's just sign it. This is what we're doing. Like, you know, we're not going to go do, we're going to come here. It just felt like the right thing to do. So here we are. It's been how long?
4 years. September 28th. September 28th is going to be 4 years. I'm still coming in every 2 weeks. And then the first time I walk in and I see that I would like to talk to Dr. Reardon, I told him, that's never forget. I told my daughter, one day you're going to see me and my daughter take a picture, and then I'll be fine. Everything is going to be fine. I would have trusted him the first day, and I trusted clinical trial the first day I came Dana-Farber.
So that was the trial that was a combination trial, right? You were getting radiation, chemotherapy, and twice weekly infusions of nivolumab, right? So that's some of these trials can often involve multiple combinations. We heard earlier from Dr. Reardon that piling on different strategies may be the most effective way, but you had a bad response. You had some bad side effects as a result of that trial.
Actually, not that much though. I
No?
was like, no.
Okay.
No.
Okay. But now you're on a different trial, right? You're just receiving a monotherapy now?
Yeah.
Just one drug. Okay. Wonderful. John, so tell me, when did you first hear the word immunotherapy, and who explained it to you?
Interesting. I'm a 32-year biotechnology engineer for a company that helped to develop and market a lot of immunotherapy ingredients, monoclonal antibodies, reagents. So I've been very familiar with immunotherapy for a number of years and knew it was going to be the thing of the future. Where it was and where it's come is just incredible. But that's basically how I got involved with it.
Denise, when did you first hear the word immunotherapy?
So we had heard about it when Cole had first relapsed, and just automatically you start to absorb as much information as you can, and you talk to different people and research a lot of different things. At the time, there was a pediatric patient, and I believe actually a picture of her was in your film, Emily Whitehead, had received the treatment. And so we knew of it, but at the time it was very exploratory and early on, and it was, when you didn't have those other treatment options available to you. So when Cole had his transplant, we knew of it, and it was always in the back of our minds. We thought that it, something that was just wonderful to hear about, and the great strides that they were making with it. So ironically, when Cole relapsed, it had only been 6 months prior that the FDA approved Chimera, which is the CAR-T agent that Cole received. So there was a lot more information, a lot of articles, a lot of discussion about it. And when we consulted with our team up here in Boston, because we also were looking at another facility, Philadelphia had been doing the trials and had a lot more pediatric patients that they utilized it with. So we had talked with them as well. And but our team here, just Cole's a perfect candidate for it. This is our experience, and so we, went with that approach.
Despite the positive information you were coming across about this type of therapy, did you still have concerns about having your son enroll in something so experimental at the time?
Yes, it was scary, and the fact that it still was new. I mean, it is still new. There's not, the number of pediatric patients still is small compared to, what you would think of other things. So And it was hard too because it was emotional at the time. So you were trying to figure out all these different things. Where should we go? And it was hard for us because we live in Florida, and I have my 2 other children, and we still had to work, and trying to juggle all of that and to figure that out. But the treatment itself was scary, but it also is so promising and it makes such sense when you think of it, that we just, put all of our faith in our doctors and what they felt was best and what we had known about it. And it was what was right for Cole.
Mm-hmm. Now, Cole, did you have any concerns about this therapy, or did you just figure, I'll let mom and dad handle it?
Well, I wanted to know what it was about and stuff, and it was very new, so I learned, and my doctor told me stuff about it, and then I don't know, just something in my head said I was going to get through it, so I was I'll just go through the motions, kind of.
Did the doctor explain to you about the immune system and cancer? How much information did you as a pediatric patient get, or was that all directed to your mom?
Well, when I had my bone marrow transplant, I was younger and I didn't want to be involved. But this time, I want to be involved with all the decisions and stuff. And so my doctor said how they take a virus and then they I don't know, put it in your cells, and it kills the cancer and stuff.
Ernestina, when did you first hear that word immunotherapy, and who explained it to you? Did Dr. Reardon explain to you what immunotherapy is, or had you heard of it before?
Was you or Dr. Reardon?
Dr. Reardon.
It was Dr. Reardon.
Do you remember how he explained it to you, or any questions that you may have had for him? It's all a fog, right? I mean,
Yeah.
You're going through way too much. You're not going to remember all those details.
We probably didn't even understand it that well, honestly. It just felt, like you said, the emotions and everything, you kind of just feel it. And I remember when she told him, she said, we're going to fight and we're going to do this, and I believe in him. She trusted him right away. I don't know what it is, Dr. Reardon, but she trusted him right away, and she's like, whatever he says, he's like, that's what we're doing. And
So John, let's get back to genomic testing is something that you're very passionate about, and it's something that many cancer patients experience, and their treatment decisions are based on that. So tell us a little bit about that process and how it's valuable.
Yeah. First of all, you probably don't know if you're a candidate or not until you have some kind of genomic testing done, whether it be done commercially, or there are several places, one here in Boston, Foundation Medicine, who conducted mine. They've got a solid tumor pathology test as well as a liquid test, so it can be done with blood or saliva. In my situation, they had my prostate pathology and were able to test it thoroughly. Like I said, found that there was a high mutation burden. And it qualified me for 3 specific checkpoint inhibitor drugs. And the decision was made by myself and my oncologist that I'd go with pembrolizumab, Keytruda, because I was quite familiar with that drug. And like I said, within 3 months, I had disease regression, and it's just been smooth sailing since. I have no severe side effects from it after 44 infusions. The only side effect I do have is I have adrenal insufficiency from it, but it's controlled with a 5 milligram prednisone, a steroid. And I have absolutely no limitations. I mean, I live a very busy, active lifestyle now. It's basically giving me my life back. How long it will continue, who knows? But I'm optimistic.
You're not just optimistic, you've become an advocate for this.
Right.
Now, what is it why do you need to advocate for this? Is this not something that's just done
No.
pro forma, or is this something that patients have to ask for?
Yeah, for the most part, I think patients have to ask for it. A lot of the forums I belong to and some of the other advocacy work all indicate that, why isn't immunotherapy working for me? I says, well, have you gotten tested? He says, what kind of testing? I says, genomic sequencing. Genetic being, checking the family history, but genomic is the actual testing of the pathology. And unless you have that done, you're not going to know whether you're a candidate or not. So, that's the first step. And I advocate heavily for foundation medicine. I travel around the country speaking for them. That's basically it. You got to start somewhere, and that's it. I'm a little surprised that it's not done a lot earlier in the process. In my case, they immediately put me into conventional treatment without knowing really what we were dealing with. But, finding out that it didn't work, brought me to that next step that, we're going to test it as well.
Have you found, in the course of your treatment, have you been treated at different types of treatment centers? Was one like a community center, or one was no? Always
No.
top of the line academic
I was diagnosed at my my personal physician's office and immediately sent into Boston. I sought out the best that I could find through my experience in the field for prostate and genitourinary cancers, and I'm being treated at Tufts Medical Center, the cancer center there by Dr. Paul Matthew, who is a leading specialist in prostate cancer as well as a researcher. And that's how I got into an experimental trial with him, because I didn't qualify for a clinical trial because of the progression of disease I had.
So just one last thing on the biomarker, or what the genomic testing revealed. You mentioned high mutational burden, which is essentially, I think Dr. Reardon mentioned this earlier. You've got so much mutation that the cancer appears foreign enough to the immune system that if you treat with a checkpoint or something, it's more likely to respond. But that's just one of many different markers that patients, and they're all different for different types of cancer. Too.
Exactly right. Typically with checkpoint inhibitors, they look for a PD-L1 factor. I didn't have that. I was microsatellite stable. You have to be microsatellite instability. So there was. They just figure it. What a remarkable story. What a remarkable recovery you've made, because you don't have any of the variants that are required for effective immunotherapy treatment, other than you have a high burden mutation. And that's what they're trying to figure out now. What part of that high burden mutation is it that's giving me the response I'm getting?
If we learn from that, how can we help other patients who don't respond to the treatment, right?
That's a tough one.
Yeah. Denise, were there any particular, as a parent of a child with cancer, there's probably nothing more heartbreaking, right, at the outset, right? And I'm so glad that you're doing so well, Cole. But were there any specific challenges in the beginning, or did things change? What were the hardest parts about this?
So the hardest part for us was, his initial diagnosis was a crazy left fielder. He was diagnosed at his regular 2-year checkup. Luckily, they did a blood test. He had a cold those few days prior. He had a blood test, and 2 of his, areas came back suspect. So they sent us, to the hospital. So that we were treated locally. We were able to keep as much normalcy as possible for our family. When he relapsed and we had to come up to Boston, that was the most difficult for us. It was something we never questioned, because we wanted the best treatment. We needed it. One of Cole's doctors, Dr. Bremeister, is here actually, and Dr. Margosian. They were wonderful. So emotionally, it was more about Cole being up here away from his support network with his friends. First of all, he was in 4th grade. He missed all of 4th grade.
Lucky, you're so lucky.
Especially because it was very intensive reading and writing that year. So that was, I think emotionally as a parent, it was hard to think, what is Cole going through? And my husband and I, we switched off and on all the time. Cole was never alone. We always spent the night with him in the hospital. He was in the hospital more than he wasn't. So, and we brought his sister Madison and brother up as much as possible when they were off of school. So for us, it became, how the heck are we going to juggle this in our lives, not only financially, but, spread ourselves out. At the same time, we needed to keep our health insurance, so we were both working. And so we just ended up starting a schedule of, like every 2 weeks trying to switch off. And you start to learn about resources and our community. We don't have family that live in South Florida with us. So our community family, with our friends, and Cole was playing baseball at the time, and they did a baseball tournament on behalf of Cole. And I remember, piping into that with on the iPad. Remember when Cole was in the hospital actually up here because he had another complication. He had pancreatitis, he had pneumonia, all these different things were happening. And so that helped from a financial perspective, and GoFundMe was wonderful. And just amazing support of people, how, you see the goodness of people coming out, which is, was great and extremely helpful.
Cole, how did that make you feel?
What?
Seeing the baseball game?
It was cool because I got to see all my friends and stuff, on the iPad when we was that FaceTime or something?
Yeah.
Mm-hmm.
And then
Skyped.
yeah, it was cool to see what I used to do, and then they're doing it. Yeah.
So, what was the hardest part about treatment for you? Can you choose?
A lot.
You have so many things.
Yeah.
Ernestina, so you participated in clinical trials. Did you have any concern? It sounds like you obviously had a lot of faith in Dr. Reardon and the healthcare team, and you came to one of the best treatment centers so you could have that faith. But were there still any other questions or concerns you had, or was it just, that's it, I'm going in?
My faith is so strong, with this clinical trial, so I'm just, how to explain this? I'm just gonna go with this. Just what I want to say that.
I think we were just so confident that I remember when she came out of surgery, this was back in Rhode Island, she said she was just waking up and she looked over at me and she says that we're gonna fight, we're gonna do whatever it is. And we didn't, I don't know if we weren't so concerned, we were just we knew that this wasn't, that she was gonna be fine. And like she said, her faith is just so strong that she didn't have a lot of concerns. I've never seen this woman cry until just now regarding this situation. She's incredibly strong, and whatever Dr. Reardon said, she was like, okay, whatever I told her, she was fine with it. Whatever she had to do, she knew that she had to do. It is what it is. I remember in the beginning with travel and stuff, and everybody's like, you're going to be so tired with all of the treatment. How can you make that drive every day? It's, like he said, about an hour and a half. We're coming from Rhode Island, and she's just like, if I got to do it, I got to do it. I don't care. We'll drive, or we'll get a hotel, or I'll sleep at the lobby, or whatever she has to do. She was just, whatever, we'll do it. So she never really had any fears, I guess.
That's good. John, advice, if you could tell yourself what you know now, if you could go back in time, what would be the first thing you would tell yourself?
I think I would probably, if the harshest type treatments, chemotherapy being one, if it can be avoided at all costs, interact much earlier with your physicians. They're the ones that are going to direct you in the right direction. in my case, like I said, I wished I'd gotten on immunotherapy a lot sooner than I did, and especially when conventional treatment didn't work for me. But yeah, I mean, trust in your physicians. They're the ones that know. Get the testing done to see if you qualify. You might not right away because, a cancer can mutate, and that changes everything in your genetic makeup. So, yeah, that'd be my message.
Denise, what would you tell yourself?
I think as a parent and a caregiver, and we've heard it, here today, being an advocate is extremely important. Becoming knowledgeable. The doctors are, it's a team approach. They have such an integral role for obvious reasons. But, as a caregiver, your child, your spouse, the person you're giving that care to. And it's really important. All those little symptoms or signs of things, always go with your gut. Don't question it. And sometimes, people may not take it so well. It's human nature in some realms. It's a very emotional, stressful time for everybody. But you're with the person most, and you know them, and it's just really important to be an advocate, find out, ask questions, be part of the team. I know, like every morning when Cole went through his bone marrow transplant, the team would gather every morning, and we, my husband or I, we would, get straight out of bed. You don't get much sleep. You get out of bed and you're part of the conversation. And this past time with Cole, he wanted to hear what the doctor said, and he was part of that too. And it's just really important to communicate and to discuss on a daily basis what's going on. And just like, what John was saying, trust in your doctors. But help them to understand the patient too. Cole had, this usually doesn't happen, but it does, veno-occlusive disease with his bone marrow transplant. His liver shut down. I think it was like 1 out of 4 kids, or 4 out of 100 kids, get it. Cole got it. And, just little symptoms. So that team approach between your doctors, the caregiver, and the patient is just very important. It helps in so many regards. I can't imagine if it wasn't that team approach.
So Cole, which medical school are you planning to go to? I'm sure you want to be a doctor now, don't you?
Yeah. Well, I think I know I want to be in a medical career, because this 8th grade I was in the medical program, and so I might want to be maybe a paramedic.
Okay.
And I don't know what school.
In middle school, he's been in the medical academy for our school, and he's going into high school, 9th grade, and was accepted in the medical academy there too. So it's definitely educated him.
I was just joking, but wow, you're really doing it. That's fantastic. Now, Josileny and Ernestina, what advice would you give yourself, 4 years ago, 5 years ago? What would you say to yourself then that you know now?
Well, the advice I would give any caregiver would be support. Just being there for them and showing them that, you're not in this alone. And you're really not. When one person in the family or someone who you care about gets diagnosed with cancer, we're all diagnosed, Yeah, physically she's going through it, but emotionally we all are. And just like you said, be faith. You got to have faith in your doctors. You got to trust your doctors, and it's a conversation you have to have with them. You can never overshare with your doctor. Mm-hmm. They have to know everything, and you have to know everything. But yeah, just support, faith.
Denise, were there any curveballs thrown your way? Not talking about not having the right responses to treatment, but things outside of the treatment itself. Were there any weird things with insurance or any weird logistical thing that you weren't expecting?
When we first were looking into CAR T, of course, we had to go through the insurance route with that. And, insurance is always something interesting.
That's putting it mildly.
Yeah. So what helped with us was that, you get denied first, and then you have to explain, like they think the doctor just doesn't know what they're talking about, why they're saying you need it. But I think what ultimately helped with us is the fact that FDA did approve just months prior the Chimera. So, but that's, I would say the typical things that you do hear about insurance. Again, for us, the whole traveling thing, but because we had been to Boston, JetBlue is a great partner in terms of, being there for people who have medical issues and reasons for traveling. They were instrumental in Angel Flight and, things of that sort. But I think, for us, it was mostly the medical, things that sidetracked us. But yeah, I think insurance and, it's always hard to juggle the work atmosphere, but their health is important, first and foremost. You do what you need to keep your insurance, but, work is that, it's just work. So, you try to juggle all those things as best as you can.
So going back to your disappointments over Cole not responding to treatment, it sounds like there wasn't any point where you felt defeated or that Cole felt defeated, right? You were just, what got you to the next thing?
Our doctors letting us know, CAR T's there. I remember talking specifically to one of Cole's doctors, Dr. Margosian. We were talking about the bone marrow transplant right before he was getting, I was like, what if this doesn't work? And he was like, we don't need to think about that now, later on. But those things cross your mind. But it was great that they just kind of put you at ease. We have options. There are things there.
I mean, you're already a mother that worries, and now you're
Right,
a
I
mother
was
of a
like,
child with cancer.
How is this coming back? I was like, he was almost 5 years. I was like, how does this happen? And then for it to come back, with a vengeance in both places, it was just, crazy. And then last year it was like, what is this? Why is this happening? So it's comforting to know that they do all the genetic sequencing and testing and, looking at it and, being part of, the people that are smart and are interested in all of this and that are doing something about it and have compassion for it. So we always had that level of comfort with the medical team. But yeah, knowing that there were choices and options and, Cancer Research Institute, making it their mission, to fund the research. I mean, that's how we're here today. And knowing that that's continuing and there's that continued effort is it gives you hope. It gives you hope that there is something there that's going to work if what you currently have done, or, what you've done or currently are doing doesn't. There's always something being looked at and researched.
Wonderful. We're going to go to questions from the audience, but just real quickly, John, is there a resource that you can recommend to everyone here around genomic sequencing? Where can people go to learn more about it?
They also hold summits like this for that specific reason, to see whether you qualify for immunotherapy.
Foundation Medicine?
Foundation Medicine in Cambridge. There are several around the country, but just so happens that that's the one I have. What I can also tell you too is that don't let the cost of immunotherapy, I mean, it's a very, very expensive treatment, but don't let that cost affect you. All the major players in this game, pharmaceutical companies, they all have patient advocacy groups where they will provide you the drug free if need be. I've had 44 injections already, and I haven't paid a cent for Keytruda. I'm part of their patient advocacy group, and where my cancer being prostate is not FDA, there is no immunotherapy drug other than Provenge that's FDA approved for prostate cancer. So a lot of all of my data goes back to Merck, being on an experimental trial, and they're tweaking the drug to hopefully make it effective for a lot more cancers, like the doctors had mentioned here. So don't let that be a roadblock. If you can't afford it, there are ways around it.
Yeah, I'm glad you brought up the access programs that the companies have. All right, so do we have any questions from the audience? We have people going around with the microphone. Please wait until they come to you. And we have our first one here. It was already on.
Sorry. Okay. Sorry. So, John, something is really interesting to me. You were PDL negative, right? Or
PDL1
negative, but you took Keytruda, which I believe you were supposed to be positive. Isn't that for?
Yeah.
So I'm just really curious how.
Yeah. When I got the word that. He says, I have some good news and bad news. I heard from my doctor. He says, you don't fit any of the criteria for immunotherapy checkpoint inhibitors.
Right.
But you do have a very high tumor burden.
Tumor burden, okay.
And like I said earlier, that's where I'm getting the response. They don't know exactly why yet.
All right.
I guess, they are trying to isolate it to find out which genetic variant is giving me a response. Because it's certainly not PDL1, which a checkpoint inhibitor is.
Because my daughter is not PDL1 positive, and so she's been told she couldn't take those. But anyway.
She must not have a very high
No, they said the
burden.
same thing as you.
Yeah.
But we're looking into other trials for that. So, okay, I wanted to really clarify.
No, good question. We have another one here in front.
My question to John.
Please hold it to your mouth. Right up to your mouth, please. Thank you.
Sorry. Question to John. Immediately after the surgery, what was your first PSA test?
Sorry, what was my first?
PSA test.
PSA.
Yeah.
It was, right from the start, I had a very low PSA, but I had a very aggressive tumor, but it didn't express a high PSA. I had a neuroendocrine component to it that doesn't express PSA. So it wasn't until after that when I, failed all the conventional treatment and had the prostate removed, had it tested, and even then my PSA never rose, more than 0.5 is as high as it went. When I got diagnosed, I was 10.5. So there was some adenocarcinoma factor there. But like I had mentioned, it was a neuroendocrine differentiation. So you can't really go by PSA.
But after the surgery, you had 0.5, yeah?
After the surgery, my PSA has been undetectable now for
Undetectable.
For 4 years since my surgery.
Less than 100.
Less than 100?
Yeah. Point.
Can I suggest,
Right.
actually, why don't you talk to John after one-on-one?
Yeah.
You'll have some time. So we have another question back there. Thank you. I appreciate that. Thank you.
Yeah, I have a question for John. What was your TMP when you started the medicine? Also, after how many cycles your doctor believe the drug worked?
I had 232 mutations out of a test at the CDX panel at Foundation Medicine. I had a pole mutation, which actually it's a DNA proofread error. But yeah, within the first 3 months of actually 3 infusions over a 3-month period, which were every 3 weeks, that I showed response on my scans. That they were keying on a pelvic lymph node because it was metastatic. It had breached the prostate. Just got into the pelvic lymph node area, and that's what they were keying on to figure out whether I was responding or not, and it had shrunk to nothing. So it was in the first 3 months I started showing response.
Great. Well, unfortunately, that's all the time we have, but there are breakout sessions after this. But for right now, let's please just thank John, Denise, Cole, Ernestina, Josileny. Thank you so much for coming up with your help. Just if you all stay put for just a second, I just have a few closing remarks, and then we'll go to our breakout session. Can we advance the slide? There we go. All right, great. So you may have selected one of the breakout sessions that is to follow. If you didn't sign up for one, that's fine. Feel free to go to any of them that you like. The general immunotherapy with Dr. Reardon will be here, but then the childhood cancer, gastrointestinal cancer, and lung and esophageal cancers are in rooms 308, 307, and 306 near the elevator bank in the middle over here. So we'll be heading out to that after a very short break. But before we go, I'd like to once again thank, first of all of you for coming here today. I give you all a huge personal round of applause because I do really cherish seeing patients and caregivers advocating for themselves and seeking out the kind of information that we're able to provide. So thank you all for being here. And then thanks to our sponsors who make this educational programming possible. Also, we like to thank, again, our advocacy organizations. We do have some literature from some of these groups in your tote bag, so there are resources you may find helpful. So please do take a look at that. And as a reminder, we'll be sending you 2 emails. We do really appreciate your feedback via our survey, so we hope that you'll fill that out. And then we'll also be sending you information, including today's presentation. So with that, I invite you all now to go to your breakout sessions. We won't be returning back to this room, so let's thank all of our patients again and our experts again. And thank you, Dana-Farber, for hosting us. This is a wonderful venue, and we hope to return in future. Thank you.